My name is Marian Fonica. I'm from Romania. I'm from Europe. I'm a dentist for 13 years. In the last 4 years, I become a more and more an endodontist. And today we are going to talk in this webinar about ensuring the structural integrity during restorative treatment. Basically, we are going to talk a lot about core buildups. We are going to talk about materials, about adhesives, and also about the procedure of conserving the tooth structure and isolation. You are going to see some clinical cases, some tips and tricks, and also I am going to show you my problems that I have, how I solve some of them, and I still have issues. We all have. So I will go to the next slide. As a disclaimer, I'm a medical consultant for Centrix Dental, but all the technique that you are going to see, it's applicable for every other core buildup on the market, for every other bonding. So stay with me, and we are going to go to the next slide. And about the definition of core buildup, we are performing sometime, I think, daily a core buildup. And what we are going to do, we are taking a tooth with a large destruction like this canine, and we try to reinforce it, sometimes with a glass fiber post, metallic post, doesn't matter. We are going to use a core buildup. We can use glass ionomer, you can use dual cure composite, and it's much better to use a dual cure composite. I'm going to show you some studies. So this is quite simple. We are doing every day. About the materials that we are going to use when we are performing a core buildup. What should we take in consideration? So a core buildup of material should exhibit good adaptation and reliable bond to post surface. So that's why we need a really good bonding, a really good adhesive system. And ideally, we should have no voids inside the material, because the voids will act like a weak point. It can cause a fracture. And a really, really important thing, it's about the shrinkage, is about the stress when the material will cure. And always a material with a lower shrinkage will have a superior and a better prognosis in time. And all the time, a product with a superior filler content will have a lower shrinkage. So if you are working with a really viscous material, it will always shrink less than a really flowable composite. It's true also for a light cure composite, also for dual cure or self-cure composites. About the classification, really simple. When you have destruction like this, so you are still going to remove all that it's decayed here. So in this case, you need a reinforcement. Doesn't matter if you are using a cast one, glass fiber post. It can be carbon post, metallic. When you have a tooth like this, let's imagine this premolar is not here, and you're going to have here a breach. In this case, you can use even glass ionomer for this case. In those cases with a large destruction, you need a really good material, really strong. And that's why all the producers you are going to see that they are saying their product, it's the same strength as a dentin. We all know that is not true always, and always the materials, the composites are softer than the regular tooth structure, and you can feel that when you are preparing a tooth. And you have lots and lots of glass fiber post, carbon post, metallic post to choose from on the market. I myself prefer a lot the glass fiber posts that have some retention, because all my failures in the past were with smooth glass fiber posts. Basically, all the cementation, it happened in the presence of a smooth glass fiber post. And take in consideration, if you are having a really good adaptation of the glass fiber post inside the root canal, if you don't have any retentivities, it's quite easy for the glass fiber post to remove all the cement or the core buildup material when you are inserting inside the root canal. If you are using the glass fiber post with micro retentivities or with some retention, all the time you'll have cement in those retentivities. So it's a way to assuring the glass fiber post will stay inside the root canal. Why to use glass fiber post? Why I'm using glass fiber post? Because there are a lot and a lot of studies there. They show that the best material to perform a core buildup and reinforce tooth structure is the glass fiber post. It's much better than using metallic post, than using titanium, even gold. Why? Because the glass fiber post from all the material available for us on the market have the closest flexural strength compared to the dentin. Even glass fiber post has a little bit higher than dentin. Look at the gold that we are considered to be one of the best material in dentistry. If you are seeing like old gold filling, they are there for 20, 30 years without a problem. Titanium, it's much stronger than dentin, and that's why when you are cementing a post inside the root canal that with a higher flexural strength than dentin, the risk is always that the dentin will fracture and you'll have cracked tooth. You don't want that. That's why when you are going to use glass fiber post inside the root canal, even if you are going to have a fracture, all the time the fracture you'll see it's above gingival line. Almost all the time, I think 99% of the time, you can save that. That is not the case with metallic ones. Basically, you're having something like a split root, like a deep fracture, and that tooth should be extracted. Again, I'm not using, when I'm preparing for the post, the space for the glass fiber post, I'm not using special boards. I'm just using Glidden gates. And I try all the time to choose the glass fiber post that it's the best fitting inside the root canal, inside the space that I made after preparing the root canal. And another advice will be, if you are performing a root canal in a session, place the glass fiber post in the same session. I'm doing all the time like this. There will be no problem to remove the glass fiber post from there. If you have any issues, it's quite easy with ultrasound. I'm going to show you in the clinical cases. And again, I don't like the smooth glass fiber post. I prefer the one that have some retentivities on them. This is the material that I'm using for I think 7-8 years. It's a core buildup. There are many core buildups materials on the market. Actually, this is my tooth. This is the first case that my colleague performed on me with this material. I still have this tooth in my mouth. You are going to see advantages. Is the same like any other core buildup on the market. So no difference on the sheet. So what I like a lot about this material, it's the cartridge. Basically, this material is the most viscous core buildup that you are going to find on the market. Why this is an important thing? Because when it's set, it is really strong from a mechanical point of view. Basically, when you are taking a burr and you are preparing the tooth, it will feel just like dentin or almost like dentin. And another good thing about this material, you have with every cartridge 2 mixing nozzle. One cartridge is enough for at least two core buildup, so you have everything that you need in a single kit. And keep in mind, to have a really good core buildup, you need a really good bonding. I highly recommend go there and buy always the best bonding you can find. If something will fail, all the time the bonding will be that. And especially when you are cementing glass fiber posts, or no matter what type of post you want inside the root canal, it's really important to have a really good adhesion there. The most common failure that you are going to see, it's the cementation. Why the cementation happen? Like 97% of the time, depending on the literature, will be because of bonding. If you are using a light cure bonding, it will be impossible to light cure it inside the root canal. So you always need a dual cure bonding inside the root canal. This is what I'm using for, I think, 7 years. I use another bonding before this one. You can go with every dual cure bonding on the market. When you need a dual cure bonding, really simple when you are going to cement a glass fiber post inside the root canal, because there is no way you are going to liqueur it inside the root canal. Why? Because you have the distance in the first place, you have the light rays that are parallel to the root canal wall, and also you're going to have some adhesive inside the dentinal tubules. You're going to have adhesive inside the microretentivities that will see no light. So you'll always have bonding that will not cure if you are using only a light cure bonding. That's why it's really, really important to use a dual cure bonding to avoid all the failures caused by the cementation. And another important thing will be the chemically compatibility between adhesives and dual cure or self-cure composite. Keep in mind, there are only a few bondings on the market that are chemically compatible with the dual cure or self-cure bondings, composite, sorry. So most of the bondings that are self-etch because of the acidic pH will destroy the catalyst inside the dual cure or self-cure bonding, and that's why we are going to see a failure. I will show you a clinical case when I fail, even if I knew that the bonding is not compatible with the core buildup. I use it. I said, come on, it cannot be like that. It was just like that. Again, there is a lot of literature on this subject, on the compatibility. Also, if you can use a dual cure, self-cure composite inside the root canal and using only a light cure bonding. So it's quite simple. If you want to avoid all the failures, use all the time a dual cure bonding. I will go further. This is what I'm using. I'm using Connexia. It's a 7th generation. It's a self-etch bonding. What is different about this one? You have the red bottle. This is the self-etch bonding, and you'll have the black bottle with the black cap. This is the activator. How you can use it? Basically, you are putting 1 drop of bonding in the mixing well. You are putting 1 drop of activator, mixing together for 1 to 2 seconds. From this moment, the bonding will become dual cure, and it doesn't matter when you're applying inside the root canal. If you like cure it or not, in 30 seconds in contact with dentin will self-cure. So it doesn't matter how deep the cavity is. It doesn't matter if the bonding will go inside the dentinal tubules. The bonding will self-cure. If you want to light cure it, you can light cure it. Where the light will reach the bonding, it will light cure. Otherwise, it will just self-cure. What I like again about this bonding, look at the dentin bond strength. It's on par with golden standard like 4th or 5th generation. The adhesion on the dentinal level, it's huge. On the enamel, it's a different story, but inside the root canal, you have dentin. You don't care about the adhesion on the enamel. 24.5, it's again high. If you want to go higher, you can use selective etching. And another thing that I like a lot about this bonding, it has water as solvent. It doesn't matter if the dentin is dry, it's wet, it has water inside. You're going to apply it, you are going to dry the solvent, and in this case, the solvent is the water. So it doesn't matter if the dentin is moist, dry, or wet, it will always give you the same adhesion. As I told you, there are a lot of core buildups material on the market. I use in the past, I use Rebuilda. I use Luxacor from DMG. I still have built it from Pentron. I still have it in my dental office, but I'm using only for small repairs, only when I have a small cavity, because it's way too flowable and you're going to have a big shrinkage. On the bondings, you always have a good choice on the market when you are going to need dual cure bonding. You have Futura DC, you have Parabond, you have Premier Bond. There are a lot of bondings on the market. But keep in mind, be sure that the material that you are using, it's perfectly compatible with the bonding. I use this combination because for 7 years I had, I think, 5 or 6 failures. 3 of them, there were a discementation, and I have 2 fractures. Both fractures were on a lateral incisor. So also it's on par with the literature that is saying that most likely to fail will be the incisor, especially the upper incisor, when you are going to do core buildup and you are going to use a glass fiber post for reinforcement. The molar premolars are not failing that much with the glass fiber post. I want to show you the difference in viscosity. So this is Anchor. You can see the quality of the material. You can see the viscosity. This is Build It. I told you I have them both in my dental office. They are both dual cure composite, so you can cement the glass fiber post and reconstruct the coronal part on the same time. But Anchor definitely has much more inorganic feeling to in his components. Is much harder from a mechanical point of view, and you don't need matrix, you don't need anything. And this will be really important when we are going to talk about delayed light curing and why this is important. As a procedure, it's really simple. It's the same as with any other core buildup on the market. What is different? It's the delivery system. So inside the cartridge, you'll have the catalyst on the base. You need the mixing nozzle. Really important thing, all the time before entering inside the root canal, express a small quantity of material. You want to be sure the base and catalyst are in equal amounts. After that, the tooth was treated with Connexa. It's a dual cure bonding. You just fill the root canal. I prefer to apply a small excess. Those are the old glass fiber posts that I used that are smooth. I don't use them anymore. So you're applying the glass fiber post and then just continue to apply the material. No need to light cure, just continue to apply the material. You see how the material will stay in place. You don't need any matrices, any cap or anything, just place the material. In the past, I used to light cure it. After that, now I don't light cure it. I will always leave the material to self-cure, and after 4 minutes, I will light cure it. Then just prepare it in the same session. If you still have time, take the impression, make the crown. As a small trick or tip, I told you a cartridge is enough for at least 2 preparation, but sometimes you are going to be left with a cartridge that has enough material that you can fill a mixing nozzle, and just to avoid the waste, you can place that mixing nozzle filled with material to another cartridge, and you can perform from one tray around 30 core buildups. So I will show you. So in this case, in this cartridge, there is only a small amount of material left, not enough for a core buildup. So I will just fill a mixing nozzle with all the material left, and fast I will place that mixing nozzle to a new cartridge. And this way, you can make from one cartridge around 3 core buildups. So this is a small trick just to take the most from one tray of core buildup. I will go to clinical cases. So the interesting part now is starting. I will show you clinical cases, nothing special. There are just clinical cases that every one of us can see them or do them daily. Even if I have a microscope, all the pictures, all the clinical cases were made with loops. The pictures were taken with DSLR, so there is nothing special. I will show you the first case. So this is the radiograph. So we are talking about 2 premolars and a canine on the upper jaw. As you can see here, there are large composite filling. The first premolar was tender on percussion. Then the patient came with a canine with a pulpitis. The main challenge here was the small quantity of dentin left, only a small part of sound dentin. So I perform a surgical crown lengthening. So just with a regular burr, I remove from the bone I perform the root canal treatment and place the glass fiber post on bow premolar in the same session. And in the next session, which I'm going to show you, I will treat the canine. I will place the glass fiber post, and then my colleague with which is a prosthetician, it will make a bridge there. So in this case, the bow premolar were treated. They were reconstructed with a glass fiber post. The canine. The patient complained about pulpitis. As you can see, a large leftover from old composite filling, a lot of decay, and the main issue is that the decay is under the gingival line, and I still have to clean something from here. So the next step will be, after removing most of the decayed dentin, I will perform the isolation. I have to do to perform a root canal treatment. Use rubber dam. I will not insist on that. I will never go to work without the rubber dam. It's impossible for me without the rubber dam. But in this case, even if I did my best, I perform a surgical crown lengthening and gingivoplasty. In this case, it's not good enough to perform a root canal treatment. You can see here some bleeding, so that's why I'm going to use liquid dam to be sure that there will be no saliva coming inside the root canal. I will perform the root canal treatment. So in this case, I perform the root canal treatment. I fill the root canal. I use backfilling in this case. I remove with a Gates burr the gutta percha. I left only around 5-6 millimeters inside the root canal, and I prepare the root canal for the glass fiber post. But in this case, because I need adhesion all around the dentin, I need to remove the liquid dam. But another problem here, when you are removing the liquid dam, you have bleeding here, you have saliva, you have gingival liquid, so that is not good for adhesion. So I will use my favorite material, one of my favorite materials in dentistry, which is Teflon tape. I use a lot of Teflon tape. So in this case, I will place Teflon tape between the tooth and the rubber dam, just to keep the bleeding away. You can use retraction cord, but I don't like retraction cord because they will get impregnated with bonding, with blood. Then the composite will stick to them. They are really hard to clean up. Teflon tape, on the other hand, you just remove it in one piece, and everything will be nice in the end. So in this case, I will use acid. Even if I use a self-etching bonding, I will always use phosphoric acid on the enamel, because I want to have the highest adhesion on the enamel. On the dentin, I will never use inside the root canal. There's no need for that. Actually, will decrease the adhesion. I all the time treat the glass fiber post with bonding. I never use silane. It's just additional step for me that I'll never do. And for that, there are some studies there that show that the silane will not increase dramatically the adhesion. It's just for the sake of the statistic. They seem only a slight improving when you are using silane. When you are using sandblasting, they saw a high decrease. If you are using peroxide hydrogen and never use hydrogen peroxide in the presence of bonding or composite, they will always lower your adhesion. So I never use silane. The most important thing when you are cementing a glass fiber post inside the root canal is the C factor. So is the ratio between the bonded and unbonded surface. And if it's in a molar, in a cavity, class 1, it will be something like C factor 5 inside the root canal. It can reach 500. So that's why you need a really viscous core buildup material with the lowest shrinkage possible. The next step, after I treat the glass fiber post with bonding, I will treat the root canal with bonding and all the remnant tooth structure. I all the time use paper points to remove the excess bonding inside the root canal. If you are going to use only the airspray, what you are going to do, you are just going to push more bonding inside the root canal. So I'm always using paper points to remove the excess bonding. I will fill the root canal with bonding. Just place the glass fiber post then and continue to apply the material. You can see it now. It looks like a mess. I'll let the material in place for 4 minutes to self-cure, and then I'll put also the light cure over it. This is how the canine look after I remove the rubber dam and I perform a minimal preparation. You can see here the gingiva after I cut with the ceramic burr, just to be sure that I will be able to perform the isolation. You're going to see from occlusal plane, this premolar was reconstructed also with Anchor. This is a blue shade. I need blue shade because in this case, because of the margin, it's ending right to gingiva. When my colleague is going to prepare the tooth, it's really important for him to know where the tooth is and where the core buildup is. So that's why I'm going to use blue shade all the time on critical situation like this. On the first premolar, there was no need. It was above the gingiva. This is the canine. You can see here the teeth after preparation. On the molar, it was another cavity. I place a filling there. This is the final bridge. It's a PFM. And you can see here the bridge. All the cases that I'm showing to you, they are having at least 5 years. So the patient are still having the bridges. Is nothing new. That's why I changed a lot on my technique in the last 5 years. Only this year I changed like 2 or 3 things on core buildup. So I all the time try to improve the things and all the time make it simple. The next clinical case, it's again really easy. So this is we are having here 2 premolar and a molar. This is on lower jaw. This is a picture taken in a mirror. So premolar were treated in another session, the molar in the same session with a glass fiber post. In this case, I decide to place glass fiber post and make core buildup with reinforcement only on the premolars. I decide that on molar I have enough tooth structure, so I will not place a glass fiber post. That was my decision. It doesn't mean it was the best decision. You can see here I'm using Glidden Gates burr to remove the gutta percha. It's quite easy to remove the gutta percha from inside the root canal with Glidden Gates without water. On low RPM, I use something like 2000 RPM, and just will melt the gutta percha, and the root canal will be clean. I'm doing the same thing on both premolars. I'm checking the fitting of the glass fiber post inside the root canal to choose the right and appropriate one. I will not enlarge the root canal to fit the glass fiber post. I will choose the glass fiber post to fit inside the root canal. If you see here, it's a small bit of temporary filling. I saw that only on the picture. It's still there. I never saw it on the patient mouth. So this is a mistake. You can see here the large destruction on the molar. That was the first thing why the patient came to our clinic to replace the old bridge, and because she had a lot of gingivitis and issues with the gingiva in this area. Again. Connection, dual cure bonding is mandatory to use dual cure bonding inside the root canal, as I told you. Again, I will perform the fitting. Just apply dual cure bonding inside the root canal on all the remaining tooth structure, premolar and molar, also on the glass fiber post. Light cure it. I will always light cure the dual bonding. I told you where the light will reach, the bonding will light cure. Otherwise, it will self-cure in 30 seconds. I will respond to the questions at the end. If we have enough time, we have a few questions until this point. I will try to respond as many as I can. So again, here I will use blue shade because it's really important to know where the limit of the preparation it's ending here, because the structure was under the gingival line. So I'll use the blue shade, just fill the root canal, place the glass fiber post, continue to apply material, same on the first premolar. I could do a better isolation here. You can judge me for that. I told you I will not show you my perfect cases. I show you cases where I made mistakes. So cases from which I have learned. So in this case, I will fill all the cavity on the molar with core build-up material. I will place more on the premolar. Don't be afraid to place more material. You can easily remove it with a burr. And I will show you here another mistake. When I applied more material, I just put it from above. I didn't put the tip inside the material, so I trapped some air bubbles there. This is an important thing. I told you from 1 to 2 years, I will never lacquer the dual cure composite, the core build-up material. I will let it to set by himself for 4 minutes. After 4 minutes, I will place the lacquer. Even in this case, I will place the lacquer only on the premolar. I will not place the light on the molar. Why? Because every time when you are going to lacquer a dual cure composite, you are always going to end up with a higher shrinkage. So in the case of Anchor, if you are lacquer the material, you are going to end up with a shrinkage around 1.24, so which is quite low compared with the lacquer composite. But if you are going to leave the material to self-cure, you'll have something like 0.46. So around 3 times less shrinkage. That's why it's important to leave the material to self-cure. There are some studies there. There are some serious studies, and it's called delayed light curing. What is delayed light curing? Basically, as I told you, you leave the dual cure composite to self-cure. After the composite self-cured, then you'll bring the light and you activate also the camphoquinone, and if it's any other monomer that didn't go to polymerization, now is the time for that monomer to get into a chain, and that's always you end up with a lower shrinkage if you are going to do that. You can see here the core buildup after setting. In this case, I will prepare the teeth for impression. You see here the bubbles. You see here the extension of the core buildup, and this is the reason why I use a contrast shade, the blue shade. I will make a provisional. I took a sausage impression here. This is just a cheap C-silicone. I will use access gram. This is a bisacryl material for a provisional. So just a regular scutan technique, nothing special. This is the provisional after taken from impression. I will cement it with the no mix. This is temporary cement. It's moisture activated. It's a quite low strength cement, and I like that because I can easily remove the provisional bridge. This is a cement designed for patient. You can give this to the patient also at home. This is how the patient came with the bridge. This is how he will live. That was the original shape of the bridge. You can see here the blue shade. It's is going through the material. It will not be an issue for PFM. It will not be an issue for zirconia. Might be an issue for high translucent Emax or ceramic, intergrass ceramic. For Emax, for zirconia and PFM, not that much. If you are going to cement also with opaque cement, that will be for sure not a problem. But I just put the picture to see how we might end up. This is the final bridge. This is right after the cementation. The gingiva is still inflamed after cleaning the cement. You can see here the extension of the bridge on the molar, just to be sure the crown will end up on sound dentin and not on the core buildup material. This is really important. Be sure that the limit of your preparation it's on tooth structure and not core buildup. It doesn't matter what type of core buildup or bonding you are going to use, that tooth will fail in a long term, maybe 5 years, 10 years, I don't know. But the bonding, the composite will fail. The best closing and the best success you'll have if your crown it's ending on the sound tooth structure. This is from the occlusal plane. Okay, clinical case number 3. This one was really challenging, and I will show you why it was really challenging. So, the patient came in our clinic for aesthetical reason. She had the old PFM bridge. Another problem was the gingivitis and the bleeding. And you are going to see on the radiograph there are a lot other issues. The lateral incisor was tender on percussion. There is a periapical lesion here. As you can see here, the metallic post, the screws are placed inside the gutta percha. So, in the first place, we have to remove the old post. We have to redo the root canal treatment. We have to place other posts, and I will use all the time glass fiber post. But as you can see, after we remove the old crown and bridges, there was a lot of dyschromia, a lot of old composites. Here we made like a mouth guard to make a gingivoplasty, just to redo the gingival level. This will use as a guide. Dental technician made it on the wax up. So this is the preparation. It was prepared with the shoulder, which is always nice when you can do it. I will use for gingivectomy the ceramic burrs. Those ceramics are from Comet. They are really good. Always use them without any water. So basically they will really clean the gingiva, and you'll have also really good hemostasis. I have also laser in my my office, but I'm not using that much because it's slow, and guide, it will always pick a lot of gingiva. It will be a mess in my opinion. Maybe it's so old, but I prefer those. The gingiva would always heal really well. Never the patient will complain. I didn't have until this moment a patient to go and say, you know, my gingiva hurt like crazy. No, always it will be really good. So in this case, I cut the gingiva just to redo the contour. Here you can see some bits. Here that will be the weak link you're going to see in the final picture. Here I should cut more of the gingiva, but the worst part with the gingiva, it's when you are performing a gingivectomy, you never know how the gingiva is going to heal. You can end up with a huge recession. The gingiva can grow, as it can happen, where it will stay as you want it, but never it happens that frequent to stay as you want it. So in this case, we made the provisional. The provisional were the impression was taken on the wax up. This is again access crown. It's a bisacrene material, and I love it because the gingiva will always heal so nice against this material. I use it a lot of implants. As you're going to see, this is I think 7 days or 10 days later. Here there is also some granulation tissue, but here the gingiva healed really well. This is after we remove the provisional bridge. You see here the gingival contour. It's looking also much better on this case, but we we need to remove the old posts. So I started to remove the composite, exposing the screws, the metallic posts. This is the occlusal plane. You can see a lot of decay, a lot of dyschromia here. This is the post after I remove it. You can see gutta percha. Even if they are gold plated, they are rusty. I don't know why. This is what I'm using for removing the usually the post. It's ultrasound tip, which is really thick. It's specially designed to remove the post from inside the root canal, and usually the post, because it's so thick, all the vibration will be transmitted to the post. You can easily remove it without any issue. This is how the teeth are looking after I remove the posts. You can see here the damage and only a small bit of the dentin left. And I will always use carry detectors, because in those cases you have such small quantity of sound dentin left, so it's quite important to keep as much as possible. So when you want to remove the dentin, remove only that it's infected. Those are exposed. There are applicators that are dry, which contain a dye for just I think it's methylene blue, but I like them because all the time the quantity is the same. You cannot overdo it. So you just apply with the applicator, with carry detectors on them, on the moist tooth, just wash it, and you're going to see after washing, it's not that much, just a small bit. I had the temptation to remove more of the tooth. It wasn't the case. So I will start here to perform the root canal treatment. I place the rubber dam, I place the clamp, also the gingival barrier here. Of course, it didn't stay because I didn't have enough ferrule effect, and the tooth was already prepared. So I'll use another clamp in this case to put more pressure on the tooth. This is the root canal treatment. You can see here a lot of gutta percha, a lot of sealer. This is not good for the core buildup. I have to clean it. I remove the gutta percha. I will always keep, and it's important to keep at least 5 millimeters from the root canal filling. So the rule is saying doesn't matter how long or how much you are going to cement the glass fiber post or any type of post do you want inside the root canal, but always leave at least 5 millimeters of the root canal treatment. There are a lot of studies there. This is not my opinion. This is a fact, because in the last 3-5 millimeters the apical delta will start, and the dentin at there is no good for adhesion, and also you are risking to put some bonding there and have some chemical parodontitis, which is not good. I will always use to clean the tooth right now isopropylic alcohol. I'm using AH plus as a sealer, so I'm using isopropylic alcohol with applicator just to clean the tooth. I'll check the fitting of a glass fiber post. As you can see, in this case, I use the thickest glass fiber post. It's commercially available right now. It's 1.8 millimeters in diameter. As you can see, there is still some space here. So the cavity is huge. I didn't enlarge it enough. That was already enlarged by the metallic screw, the post. In this case, even if I have dentin, I will use acid on all the dentin, not inside the root canal, but on the dentin, because this type of dentin, the sclerotic dentin, is the worst medium for adhesion in all dentistry. Maybe the temporary teeth on the children to be as worse as this, because this dentin has more in common with the enamel that has in common with the dentin. It's hypermineralized. After you are going to use phosphoric acid, even now you are not going to have too much microretentivities as you are going to have in enamel. But it will help my adhesive in this case to have a better adhesion. So all the time when you have sclerotic dentin, use acid on that. Again, there are a lot of studies. You can see here the dentin is much cleaner. I will use bonding inside the root canal on all the remnant tooth structure also. All the time use paper points to remove the excess bonding from inside the root canal. The steps are the same as any other bonding. Use air spray to evaporate the solvent, and as I told you, in case of Connexo, it's water, so there is no need to be afraid if the dentin is too wet or is too dry. But don't work in the presence of saliva. In this case, I will fill the root canal with core buildup material. This is again on core. I will place also on the edge of the preparation. I will place the glass fiber post, add more material. As you can see right now, is looking like a mess. Doesn't matter. The final shape it will be given by preparation with a burr. I will do the same thing for all the teeth. I did that in the same session. It took me something like 3.3 hours, of course, with breaks for patient. I tried first to do the root canal treatment on all teeth at the same time. It wasn't possible because of the isolation, so I have to do it one by one by one. This is after preparation, and there are still some issues. There is still some pigmentation here. It's a dyschromia again. The final crowns will be made from Emax, and because we wanted to be also aesthetic one, it was a medium opacity. So the risk is that those discoloration will go through to Emax and will affect the final shade. We cemented with opaque cement in the end. We tried. We took the try-in paste and determined that the best option will go to be and cement with opaque cement. This is after placing the retraction cord. This is the radiograph after performing the root canal treatment and cementing the glass fiber post. Yeah, the root canal treatment is looking good. And what I want to show you, so this is the glass fiber post, and it's important to have the core buildup as thin as possible. The thinner the material is, the lower the shrinkage. So in this case, I'm pretty pleased with the outcome of this treatment. This will be the final impression for the crowns. Okay, this will be right after cement, I think 5 days after cementation. You can see here a small problem with the gingiva, because in this case I place a retraction cord to push the gingiva away. When I clean up the excess cement, basically I have to make a lot of damage to gingiva to remove all the retraction cord from there. So that's why from that moment I will always use Teflon tape for cementation. I will not use retraction cord. The gum line is looking good though. This is, I think, 1 month later. As you can see here, the gingiva heal well. The triangle start to fill up with gingiva. What I don't like here on the left central incisor, the gingiva is not at the same level. I will not perform a gingivectomy here, but as I show you in the beginning of the case, I should cut more from the gingiva from the start, but you never know for sure how the gingiva is going to heal. So that is more like a lottery. This is the final result. The patient is quite happy. In the meantime, I perform also a veneer on the premolar. I was really afraid about this lateral incisor that is going to fracture. The patient still has her crowns for 4 years. I think they will stay more in place. Okay, some things about the failures and why the core buildups fail. By the way, those cases were in the same day. Fractures all the time with a metallic post with the screws. Because they don't have elasticity, they tend to create a lot of micro cracks inside the tooth. Even if you are not going to see the root fracture there are always some micro fracture there. The literature will say the most common failure when you are performing a core buildup and when you are cementing a glass fiber post, it will be decimentation. Basically, the core buildup will come from the root canal like a carrot, like you are removing a carrot from the ground. Why? Because most of the time, dentists are not using a dual cure adhesives. I did the same thing, I don't know, 2-3 years. I used just the bonding that I had in my dental office. It was OptiBond Solo Plus back then. So I used to cement inside the root canal with OptiBond Solo Plus. I didn't have too much failures, but there were a few. Later, I discovered that there is a much better bonding on the market, a dual cure bonding. So I told you, it doesn't matter the brand name, just use a dual cure bonding to avoid the risk of decimentation. Again, another issue may appear if the root canal treatment was made with eugenol in presence. We all know composites and eugenol don't like each other at all. And once again, don't use peroxide hydrogen inside the cavity or inside the root canal. That will mess up with the reaction of the bonding or composite. You're going to have free oxygen there, and you'll have oxygen inhibited layer inside the root canal. I will show you my first one of my first failures: incompatibility between bonding and dual cure composite. Keep in mind, if you are going to use a bonding and it's not a dual cure bonding, it's a high how can I say, it's a high chance that that bonding is not chemically compatible with the dual cure composite. So in this case, this patient came to the dental office because of the cavity. It was a gingivitis. She never complained about pulpitis and anything else. This tooth was vital. That was strange. This tooth was not tender on percussion. It responded positive to vitality tests. So a huge problem was placing the rubber dam and a rubber clamp. In this case, I perform a gingivectomy. This is the first thing I will do when I have large destruction. Even so, I wasn't able to place the rubber dam as I placed. So I use again a lot of Teflon tape here to push the gingiva away to keep the bleeding. I place also Teflon tape in the pulp chamber to be sure that I will still have a cavity here to make the root canal treatment. Here I had such a nice fresh cut dentin. So because I was lazy, I took the bonding that I have it on my near me. So in this case, I use G-bond from GC, but it doesn't matter. It's the same for any other self-etch bonding. Most of them, there are a few out there on the market that are compatible, but most of them are not chemically compatible. Even if I knew that, I said, come on, it can be like this. So in this case, I reconstruct the distal wall, of course, with the blue shade of core buildup material. I use, again, Anchor, because I want to see the limit of my preparation. So I use G-bond. Then I perform the root canal treatment, one of the worst root canal treatment from a radiographic point of view. The patient is fine. I wasn't able to find any distal root canal. It was so calcified after 5 millimeters, I gave up. And the patient came to my clinic 5 hours later, complaining that the posterior filling fell. In the first place, I said, come on, it's not possible. Usually, maybe the provisional will go away, but it never happened like this. And when the patient opened her mouth, that was the case. Basically, all that I placed there just dismantled without leaving any bits on the tooth structure. The dentin was as clean as I placed it. So be careful when you are using bonding. Be sure you are using mostly a dual cure bonding, because every dual cure bonding is chemically compatible with a dual cure self-cure composites. In this case, I use Connexio. I use a compatible bonding. I place 2 glass fiber posts Rarely I will place two glass fiber posts. 99% of the time I will use a single glass fiber post. In this case, because the distraction was a little bit too large, the patient will going to have a bridge here. I prefer to go with two glass fiber posts. This is the initial preparation. This is the preparation also with the premolar. This is with a retraction cord. This is the final bridge. It's a PFM. It's an extension, basilar extension. The patient refused the implant in the first place. This is the first thing that I'll propose to the patient when it's something like this. The implant will, I think, will have a better outcome. But still, the patient will she'll have this bridge that past like 6-7 years. It's still there. It's looking nice also. An important thing to keep in mind: the ferrule effect. This is, I think, the most important thing when you are performing a core buildup. Be sure that you have at least 1-2 millimeter above the gingiva of tooth structure. And be sure that the thickness of the remnant tooth structure is at least 1 millimeter. This is a well-known thing, so be sure that you have at least 1.5 up to 2 millimeter on the occlusal direction, and you'll have around 1.5 to millimeter thickness. So the studies didn't show any major difference in the ferrule effect when the ferrule is like 1 millimeter in height and 3 millimeter or 6 millimeter, but it found a huge difference between 0 and 1. So if you don't have enough tooth structure, you have to create it. You can perform a surgical crown lengthening. Sometimes it's not possible because you'll expose the furcation. Sometimes it's not possible because of the aesthetical reason. Imagine on the central incisor, the upper central incisor, you're just going to mess with the gingival line. But be careful you have enough tooth structure. If you don't have enough tooth structure, just extract that tooth. An implant will be a much better option in this case. So the ferrule effect, it's one of the most important things. This is not my case. It happened to me also like this, but I didn't took a picture. So I took on this and I want to share with you. So in this case, this is a glass fiber post, and the patient came with a fracture. This is a wall from the vestibular part. Of course, as always, it's a lateral incisor. All the failures that I've seen, they were all on the lateral incisors. I don't know what happened in this case, because as you can see, the glass fiber post, it's almost clean. The root canal, it's really clean. I don't know if that was an issue with the bonding. I don't know if the dentist cemented the glass fiber post inside the root canal with cement. What the reason between self-etching, self-bonding cement and using bonding and core buildup will be is really simple. Imagine that if you are using a self-etching, self-bonding cement, let's say something like U200 from 3M, Bischem, you are B-Fix, any type of cement, you're going to have an adhesion something like 5-10 megapascal to the dentin. On the other hand, if you are going to use a bonding like Connexio, that will give you almost 40 megapascal. So we have between 4 and 8 times more adhesion. And also from a mechanical point of view, the cement is designed to be really thin. It's not designed for mechanical resistance. So use core buildup material for core buildup, cement for cementation of the crown, not of the glass fiber post inside the root canal, except when you have a really, really good fitting. Crown lengthening is really simple. Our aim is to have at least 2.53 millimeter above the bone, because otherwise you are going to mess up with the biological width. What will happen when you mess with biological width? If you have a thin biotype gingiva, you're going to end up with a recession. On the thick and fibrotic gingiva, you're going to have scar tissue, but mainly you are going to end up with deep pocket development. So that tooth will be a success from a core build-up point of view, but will be a failure from a parodontal point of view. You'll end up with a gingival socket there, so that will not be nice. Be careful when you are preparing also for the post. You have enough be sure that you remove all the sealer and all the gutta percha from inside the root canal. So working with loops will be at least with loops. I will not say go there and buy microscopes. Just take some loops, 2.5 free X magnification with light. That will be more than enough. I told you all my clinical cases were made with loops and a source light. Be sure you are removing all the sealer and all the gutta percha. How you can do it when you have like a narrow strips inside the root canal, just with a Gates burr, I'm just brushing the walls, and you'll end up with sound dentin and clean dentin. Root canal post shorter than the length of the crown. This is mainly true for the posts that are metallic. So what we'll say, if your crown is 6 millimeter, be sure the glass fiber post or the metallic post better will be at least 6 millimeter inside the root canal. Otherwise, you are going to have a leverage that will going to do to the fracture, and you don't want fractures. Those are the conclusions. What the conclusions are: preserve as much as possible dentin. So that's why you want to use carry detectors, just to be sure you are not removing more than is needed. Even if I'm using a microscope, I'm totally dependent on the carry detectors. Avoid contamination of the root canal system. I will not stress that, but the rubber dam is mandatory in my opinion. And also in my opinion, the endodontist should do the core buildup. They know better the root canal they just treat. They know better what the glass fiber post. They see the obturation. They know exactly the length of the root. Another important thing, as I told you, use always dual cure adhesive inside the root canal. You don't want to have the cementation. That it's not nice. Then keep always a dual cure adhesive for the root canal. That's I'm always using. When it's needed for a post, use a post. I will mostly use on the premolar or on the endodontic treat and premolar. I will always use glass fiber post because I've seen premolars have a higher tendency to fracture. And always, if you are going to follow this principle, the success it's quite high. In literature, the success will reach up to 97.5, which is quite high. I don't know which other procedure will have such a high success rate. For me, it's something like 5 minutes to place a glass fiber post from all the stomatological procedure. I think this is one of the easiest. And let's see now with the questions. Please let me know. We still have something like 3 minutes. That will be something something fast to respond to your question if you have something. So any other questions? It was a question basically. To remove the gingiva, I use ceramic burrs. Those ceramic burrs are from Comet that I'm using. If you don't have ceramic burrs, you can trim the gingiva really easily with the burrs that are designed for polishing the composites. But again, don't use water. You want to cut the gingiva, and you'll have also hemostasis on the same time. Of course, you can use laser, you can use a scalpel when you want to clean lines, when you have something more to cut, you can use a scalpel. But I prefer the ceramic burr, where burrs designed for polishing the composite, just to have hemostasis. One question was if I will recommend customized metal post by taking an impression inside the root canal. This is a high topic. All the literature, all the studies shown that it will be a poor option compared with a glass fiber post. Why? Because the metal will not have elasticity compared to the glass fiber post. You have to enlarge more the root canal and always be more expensive for both the patient and the dentist. What is the difference between Centrix DC and Encore? Encore DC mini mix is the core build-up. What did I use for temporization and hold the gingiva in place? That was Access Crown. It's a BIS acrylic material. It's a composite material, and that's why the gingiva is healing really, really well against it. Even on the patient with really poor hygiene, I've seen gingiva really, really nice healing even after a large surgical intervention. Wow, there are a lot of questions. Thank you all. Thank you for your presence. I have more clinical cases. I want to be sure I can send to you all. And from my mistakes, maybe you can learn more. I still have learned to learn also. My email and all my data, I think, will be given to you. I don't know how we are going to do. I'm just going to speak with the guys from Centrix also. I want to thank Viva, and we'll get to you. I will send you all the materials, all the studies, everything you want to know. Yeah, so everything is public. Thank you. Thank you once again for being so many here today. It was a pleasure. We are going to do it also in the future with other challenging clinical cases. Thank you once again. See you. Bye-bye.